follow up as per the routine. Thank you. I will hand over now to Amit. But before that, I just need to discuss that we have discussed in this scenario quite a lot of things. Start from initial presentation to emergency department, and the role of acute medicine, including the presentation, criteria, and also including COVID complications. And finally, we have discussed about the situation when COVID patient can have a cardiac arrest. How do we need to deal with them? And second, and the last but not the least, we discuss about the discharge planning and the follow-up. Thank you.
Thank you so much, Dr. Habib, Dr. Omar, Dr. Nabil Sultan. Very, very informative session, at least for me. I'm sure definitely for all of you guys up there too. So I'll start off the question and answers. The first question which was put up was that how much time, and I'll leave it to all the panelists there, how much time an emergency medicine person takes to call an acute internal medicine person? Is that the right question? Whoever has posted this question, I'm more than happy for him or her to come forward and ask this question live. They can unmute themselves. If this is the question or anything else they need to add up before the panelists are able to answer the question, please. So we'll take this as a question.
Okay.
Yes.
So I need to actually just specifically mention that there's two things. First thing, when the ED colleagues find out that the patient need a admission to acute medicine, they can just do telephone referral to us. They can just call us and explain them about the scenario. And then we will decide on the basis of that, whether we need to come and see the patient or we can just directly send them to acute medicine. We also run ED in reach service, which is a very important component that where we normally do and visit ED on regular basis. And the team consists of senior physician, including consultant or senior registrar, plus junior doctor and ANP, advanced nurse practitioner. And we need to make sure we do some type of like triage service. But like in this scenario, if the ED people think this patient need acute admission to acute medicine, then we normally accept them because we are dealing with the COVID era. So we need to minimize the risk of exposure in terms of safety to others and including the staff.
Yeah, I'm just not to mention a few more things. Sorry, I guess.
Yes, Doctor.
How long does ED take, or how long does an emergency physician need for this kind of patient to refer to acute internal medicine? I guess it depends from patient to patient. So for the purpose of this scenario, the only thing we need to establish is whether this patient has COVID or not, which is usually done based on symptoms and then an imaging. So the imaging takes about, like I said, 5 or 10 minutes, but the blood results will take anywhere between 1.5 hours to 2 hours. The second time delay would probably be between the patient registering to the front door and the time that the clinician has seen this patient. So the basic idea from emergency medicine point of view is to establish our diagnosis, to do your basic management, that is to stabilize this patient. If this patient is stable and safe to go to a ward and stay stable until the next physician has seen this patient, that is all the time you need. Like I said, we've got a target of 4 hours to get this patient out of the department with a diagnosis and with the management done. Usually with this kind of patient, we probably would need anywhere between 1 hour to 2 hours to make our diagnosis, do what's needed at the doorstep, and move this patient on forward. We usually do not ask for these patients or any other physician to come and visit the patient. This patient will be referred on a phone, and once the bed is available, this patient will then be moved on to the ward to be seen in the ward. Certain kind of patients who are really sick and unwell, which you will see in the next few scenarios, will need a specialist to review in A&E before this patient's moved anywhere, just to have a more continuity of care and a proper handover face-to-face to avoid any complications and any mishandling of the patient. So it just varies from scenario to scenario and patient to patient really. I hope I've answered that question.
Yes, please. Thank you, Dr. Habib, Dr. Omar. The next question is from Dr. Fuad Abid. There are several patients in the community who had mild to moderate COVID pneumonia. They were never admitted in the hospital. Who would follow up these patients with a 12-week chest X-ray, or etc., whatever the follow-up is? Panelists, please.
So if patient have mild to moderate pneumonia and they're not fulfilling the criteria for admission to the hospital, then I think it's very important that somebody should take the responsibility to look after their care. And the GP played a very important role regarding these scenarios. And they're doing a great job during COVID era. And they have a virtual clinics. Sometimes they can do telephone follow-up. And recently in Derbyshire and Nottinghamshire, they created a different hubs, what we call red and green hubs, in which they need to make sure that patient has a feature of pneumonia, either it could be related to COVID-19 or something else. If they have COVID-19, they're going to take proper precautions to follow up them. We'll start with a telephone follow-up, but if need to physically, they can do follow-up them, including some investigations. As we discuss about, start with a simple investigation of chest X-ray, and sometimes they need to do pulmonary function tests. But the patient, those have multiple comorbidities, including diabetes, hypertension, and also they have a heart problem, or unfortunately due to have like high body index, they have more risk. So they need to follow them on more closely and decide whether they need further investigation. So it varies from cases to cases.
Thank you, Dr. Habib. Has anyone got any other questions? As I said earlier, if anyone has got any verbal, want to ask any verbal quick question, we're more than happy to entertain that before us move on to the next case. So if anyone's got a question, he or she can unmute him or herself and ask a question. Otherwise, I'll move to the next case. Just before moving, yes, someone asked this question, and that will be recording. So apologies, yes, there was a bit of a glitch in the first place, but yes, we are recording this session now. We're live on the Facebook and on Yaran Watan's Facebook page too. Thank you. So I'll hand it over to Dr. Umar for the next slide, for the next case to start over, and I'll mute myself. Thank you. Dr. Umar, over to you.
Okay, guys. So I hope you've learned something new from our first case in a patient's journey, who's a mild to moderate COVID patient who's come to the hospital and he's been admitted and who's then hopefully subsequently discharged. Our second case is rather a serious case which we've selected for you, just to give you an idea how we deal with more serious COVID patients who present to the emergency department and then been taken on in their journey into the hospital. So it's about a 38-year-old female who was found collapsed at home. She was cyanosed, blue, found laid on the floor with oxygen saturations of 76% as opposed to more than 94% in a normal patient. When she was brought to the hospital, the crew who brought her in, or the ambulance service who brought her in, gave her full 15 litres of oxygen on a non-rebreathe mask. When she entered A&E, her oxygen saturations was 92 on the 15 litres. Obviously, like I said, in everyday ED setting, the first step is to establish what kind of patient we're getting through the door. Now, this patient fills criteria at the doorstep as a COVID patient because she's cyanosed, because she's needing oxygen. Therefore, she's brought into COVID side of the A&E. And within the COVID side of A&E, she's brought into the resus side of A&E, which is the most intense and most sort of serious patients stay. She's investigated thoroughly. So the first things that we start doing is obviously starting with monitoring of the patient, start with IV lines as we do with all patients. We will take their blood samples, including cultures for sepsis and infection, and we'll do a quick chest X-ray. On the bedside, so in 5-minute bedside chest X-ray shows she's got bilateral consolidations, patchy, obviously. She's very tachypneic with us, she's very tachycardic, she's hypotensive, bloods have gone, including cultures. After about an hour and a half, blood results will come back. But based on this information that we have at the moment, we will treat this patient as a potential sepsis. Obviously, antibiotics have been given, fluids have been started, catheterized to monitor urine output right from the offset without waiting for blood results. So within the first hour, this treatment has already been given to the patient from the time they've booked in. Now, blood results have come back. This patient has got acute kidney injury, so kidney functions is gone down. On a background, this patient is usually fit and healthy, no medical problems. We've nebulized this patient because she was wheezy. to support her breathing. We've started fluid resuscitating her because the cardiovascular system has gone down. She's tachycardic, she's hypotensive. Like I said, we've given her antibiotics already to cover for possible sepsis. And she's got raised inflammatory markers, so her white cell counts up, her CRP is massively high. So the two things we do for inflammatory markers on a routine blood test right at the doorstep is FBCs and CRP. Based on what I've sort of researched so far in the COVID management in Pakistan, this patient fulfills critical disease criteria. So ideally, if the patient has any of the three, which means ARDS symptoms or multi-organ failure, which is kidneys, hearts, and livers and other things, this patient does fulfill that criteria, and then this patient is in septic shock because of high raised lactate and low blood pressure. So we've assessed this patient. We've recognized very quickly that this patient is really unwell. We've started basic treatment, resuscitation within the emergency department of symptom control and of management and resuscitating this patient. All of that is done within the first hour of management. Now the next step in the emergency physician's mind is where this patient's going to go and what am I supposed to do with this patient. The first treatment, which we've already started, works as a reflex. We do not need to tell our nurses or the staff to do these treatments. It's an automatic process whereby this recognition is very early recognized in A&E, whether there is a clinician or not, and the treatments is initiated very early. However, the escalation or the destination is then decided by the clinician. So whilst we're working on the rest of the things on this patient, we're then thinking about what could go wrong and where do we have to, or what kind of help do we need. So if I'm the emergency physician dealing with this kind of patient, the things that I'm preparing myself for is this patient's really unwell. Worst case scenario, if she goes into cardiac arrest, is there staff available to start CPR? So in the previous scenario, like Dr. Nabil's explained to you, we need to be donned properly. So I'll have one or two of my staff members ready at all times, looking after this patient, to be ready in case things go wrong, and we're prepared to start CPR. The second step is for me to then liaise with the intensive care team to get them on board with this patient, and preferably get them down into A&E so that they can take a handover verbally, physically looking at that patient, and also deciding whether this patient needs intubation in the emergency department or preferably in the intensive care where it's more controlled environment. So that's the destination. In terms of acute internal medicine, we obviously omit that step because this patient's really unwell, needs at least a level 3 care. So at this point, I will speak to the intensive care consultant, and I will explain my scenario, and I will explain the gravity of the situation, and ask their help to actually come down physically and assess the patient. With all of this going in the scenario, we cannot forget about the psychosocial aspect of this patient and the patient's attendance, because as we all know, and obviously in Pakistan as well, we do not allow patients' relatives to come to the hospital, which means that they've last seen this very unwell relative of theirs or loved one of theirs at home, and they know that this patient's unwell, so they really want to know what's going on when they're at home. So my next job after I've spoken to the intensive care is to then speak to the family members on the phone and explain to them what the scenario is, what the situation is, how things are going to go, and where we can support them and what sort of support do we have. Without obviously taking things further, I would now pass the baton on to Dr. Nabil, who would explain to you how intensive care then interacts with ED and how they manage this kind of patient in this patient's journey into the hospital. So over to you, Dr. Nabil.
Thank you, Omar. It was a nice explanation of the patient who is requiring obviously an intensive care support. So there are different ways of managing the patient. Once we receive the referral, obviously we go and assess the patient, and then we will decide according to the urgency of the situation, either this patient needs a level 3 care. I mean, and as Umar has explained, this patient is likely to be needing a level 3 care. So we need to make a plan where is the appropriate management should be started. And as we know that, and we are suspecting that this patient is COVID-19, so the earlier the better. And then we will decide that it's better to take this patient early to the intensive care unit and start the management there. And as you all know, guys, that anesthesiologists, especially in the surgical ICUs and the anesthetist ICUs, they contribute considerably to the management of the COVID-19 patients. And a very high percentage of the patients, obviously around more than 60% of the patients who come to the ITU, they require active invasive airway intervention. And those who are critically ill, they may sometimes benefit from ECMO, which is the extracorporeal membrane oxygenation. And these are the two fields which the anesthetists are expert in. So in order to have the safe approach and which is safe for the patient, first of all, the protection of the healthcare worker is of prime importance. But the protection is not only for about PPE, but it encompasses all the principles of infection prevention and control, and a better communication between the teams who are managing these patients. And then secondly, obviously strict adherence to the use of the personal protective equipment. I'm mainly stressing here about the personal protective equipment, because which plays a key role in reducing the transmission of this viral load to the other healthcare workers, including procedure mask, eye protection, gowns, and gloves, and which is quite highly effective in limiting droplet and contact transmission. So what we need to do, so once we know that this patient is safely transferred to the ITU, and now we will make arrangements to ventilate this patient, then proper PPE consideration should be taken. A particulate respirator should be worn by the team who is going to be involved in the acute management at that time. And then eye protection through the goggles or disposable face shield should be worn by the healthcare individuals. And the gown with the fluid resistance and two pair of gloves should be worn by the healthcare workers in order to prevent the contamination. So the careful attention should be paid on donning and doffing of the personal protective equipment in order to avoid the potential exposure and self-contamination. After removing the personal protective equipment, the healthcare worker should avoid touching the hair or face before cleaning their hands. As I mentioned in my previous scenario, that hand cleaning is really important. Once you doff the personal protective equipment, then the healthcare worker have to clean their hands, and then personal protective equipment should be disposed of carefully in a touch-free disposal or a laundering bin. Now, what are the criteria which can escalate the patient care? I will discuss some the escalation criteria here. So, as we have seen in this patient, if there is an increasing oxygen requirement, and the oxygen saturation is coming down to less than 88%, and when there are X-ray findings which are suggesting of bilateral consolidation or pulmonary infiltrates and increasing shortness of breath and coughing, then this is the criteria when we will decide that this patient needs the level 3 care or level 2 or intubation and ventilation. The guys here, I just want to briefly discuss you about the three viruses which we have seen quite recently in the couple of decades, which is about COVID-19, SARS, and MERS. So we all know that we are still having this MERS, Middle Eastern Respiratory Syncytial Virus. We still see the cases, but what is the difference among these three viruses and the epidemiology and the mortality among these? Fortunately, I can say that still the mortality of the COVID-19 compared to the SARS and MERS is still low, which is about 3.7% compared to 9.8%, 9.6% with the SARS and 34% with the MERS. But as you can see, the CT findings are slightly different compared to the COVID-19 patient with the SARS and the MERS patient. We can see the multifocal patchy ground glass opacity in a COVID-19 patient with subpleural distributions and progression into diffuse heterogeneous consolidation in a COVID-19 patient. While we can see the subpleural ground glass opacification and consolidation in SARS as well, and the bilateral and basilar and subpleural airspace extensive ground glass appearance in the MERS as well. And as far as pathology concerned, the lung in the early phase of the COVID-19 patient, there will be a lung edema and proteinaceous exudate with globules and patchy infiltration, cellular infiltration. But in compared to the SARS, we have got a bilateral lung extensive consolidation, localized hemorrhage, and necrosis has been noticed in the SARS patient. And but in compared to the MERS, will be a necrotizing pneumonia, pulmonary diffuse alveolar damage, and the other organ involvements also happened in the COVID-19 patient, which include the mild interstitial mononuclear infiltrates in the heart, and in comparison to the in SARS, which include the massive necrosis of the splenic lymphoid tissue, systemic vasculitis, thrombosis, and in small veins, and degeneration and necrosis of the parenchymal cells in the lungs. But as compared to the MERS, there is acute kidney injury, portal and lobular hepatitis, and myositis and muscle atrophies has also been noticed. Now, in terms of further management of this patient in the ITU, as I have said earlier in my talk, that we need to make sure that the aerosolization, minimization of the aerosol generation has been practiced, and how we can manage that. So the airway management should be reserved to the most experienced anesthetists which is available at that time. A thorough pre-oxygenation, normally we will normally pre-oxygenate the patient to denitrogenate the oxygen. But in this COVID-19 case, a thorough pre-oxygenation with 100% oxygen and a rapid sequence induction intubation should be considered to avoid manual ventilation of the patient, which can result in aerosolization of the virus from airways. Awake fiber optic intubation is generally not indicated, but if it can be avoided, is much better, because it will expose the viral load to the healthcare workers. Tracheal intubation, rather than, as I said, that rather than LMA is favored, but this patient is obviously going to be ventilated. So this, in any case, this patient needs the ventilation. Now, initiating the mechanical ventilation, and what are the modes of ventilation that is appropriate for managing this patient. I'll just go through into that detail in few of my next slides. We will initiate, the patient can be transferred to the organ for the organ support, especially the respiratory system, cardiovascular system, and if needed, like as my colleague said, that patient has got an acute kidney injury, so she might need filtration as well. So the airway team members, which are the charge of the ventilation after the intubation, once the patient is intubated and there has been effective which we know that is a COVID-19 patient, the protective mechanical ventilator strategies can be performed, and the prone position ventilation, which has played a very important role in the managing the ARDS patient, has been practiced. So I will just briefly discuss what is lung protective mechanical ventilation strategies. It includes, normally we ventilate the patient around a tidal volume of around 8 to 10 mils per kg. But this, for this case scenarios, we normally go with a low target tidal volume, which is around 6 mils per kg predicted body weight. And we'll keep the plateau pressure of around less than 30 centimeters of water, and aiming a saturation of around 88 to 95%. And we are aiming to keep the pH of more than or equal to around 7.25, and intermittent recruitment maneuvers, and like as I said, intermittent prone positioning of the patient. Ultrasonography is another field which has been progressed quite recently in the last 1 decade, and especially its role is increasing in the ITU. Ultrasonography is also been useful to quickly assist in the diagnosis of the condition, such as pleural effusion and pneumothorax early. And ultrasonography can also be used in airway evaluation and determining of the tracheal tube depth. Now, I would like to discuss the mode of ventilation which has been practiced quite successfully in the few years, and that has been practiced especially for the COVID-19 patients as well, which is the APRV. This is the airway pressure release ventilation. This method was first described in 1987 by Stock and the colleagues, who demonstrated that arterial oxygenation and carbon dioxide clearance were improved using the APRV compared with intermittent positive pressure ventilation. APRV is a pressure controlled mode of ventilation that delivers an almost continuous positive pressure with intermittent, time cycled, short releases at a lower pressure. By maintaining a prolonged high pressure, APRV maximizes the recruitment of available lung tissue and therefore improves oxygenation. This is in contrast to conventional ventilation modes, which we normally use it in ITU, in which a briefer periods of recruitment is used, followed by PEEP to prevent alveolar collapse. But when using the APRV, prolonged time at an increased mean airway pressure maximizes alveolar recruitment by providing a longer time to achieve a homogeneous ventilation and gas distribution between lung units that have differing compliance. As we all know that a patient with the COVID-19, the lung compliance in different parts of the lung is different, but maintaining a prolonged pressure into the alveoli improves the gas distribution between the lung units with the differing lung compliance. But during APRV, the patient is normally encouraged to breathe spontaneously throughout the respiratory cycle, and this facilitates gas exchange, maximizes continued recruitment of the lung tissue, promotes venous return to the heart, and prevent wasting of the respiratory muscles. But in contrast to, obviously, there are some contraindications of using the APRV as well. The contraindication which may include is obviously if the patient is not fit for, if the patient needs paralyzing and complete paralysis, then obviously APRV is not the mode. But as I said that in COVID-19 patient and ARDS patient, we encourage the patient to breathe and improve the oxygenation in different lung units. So hence APRV is a better mode, and it's been widely practiced in UK, and it has got a convincing results as well. So, so in terms of APRV, which has still been practiced, we still have not much data to prove that how effective it is for, especially for the COVID-19 patient, which I'm sure we will have something come up in later on. But along with this ventilation, obviously we need to tackle the complications of the COVID-19, especially in ITU. The first and the foremost complication is obviously pulmonary embolism. So then we have to treat them according to the therapeutic anticoagulation or the delta power. If pleural effusion or pneumothorax can happen, we have to deal with those complications as well. And as I mentioned, that complication like acute kidney injury, then we need to put the patient on a filtration, and myopathy and ICU delirium. These are the common complications related to the ICU, which we deal along with the management of the COVID-19 patient. And once the patient, obviously we are ventilating on APRV, we'll start, as I said, we encourage the patient to breathe spontaneously. But after, and once we see that there is a recovery started to come on the parameters and the oxygen requirement is coming down, then we started to wean the patient from the APRV. And we always begin the weaning by reducing the FiO2. And once we reach the FiO2 of around 0.4 to 0.5, then we started to reduce the high peak pressure, which we initially adjusted to maintain the continuous pressure throughout the ventilatory cycle. Once the high pressure is reduced to 20 centimeter of water, the time will be reduced to 1 to 2 seconds. Each time the high pressure is decreased. Continuing this will wean the patient to a CPAP of less than 10 centimeter of water with minimal releases. And this allows the clinician to assess a patient to ready for extubation. and once we extubate the patient, then we will discuss the patient and for further management, and then think of then we can decide the plan for further discharging this patient from the ITU to the ward area or a high dependency unit. Next.
That's fine. I think that ends up the case number 2. Thank you so much, Dr. Nabil. Do you need to add up anything before I start taking the questions, please? Dr. Nabil, can you unmute yourself, please?
Yes,
No, that's it.
fine.
Fine. So we've got a couple of questions. First of all, thanks a lot, Dr. Nabil, for quite a very detailed and informative session. So I've got a few questions. The first one is from Mariam. It says, in a pediatric setting, for the scenario of CPR, the most common cause of arrest is respiratory. Has the APLS logarithm changed like that in adults also?
As I said, previously, that because obviously if we know that it is a COVID, we have seen quite recently for the last in this COVID-19 pandemic that COVID-19 has less likely to be infected the pediatric population. So the guidelines has not been changed, but obviously I don't deal with the pediatric basically, so I'm not really sure about if there is any guideline. But obviously the guideline is the same. If you are dealing with a COVID-19 patient, you have to take the usual precautions in managing the patient and approaching the patient. That's the same for the pediatric and the adult. But I'm not really sure about if there is any APLS guideline has been changed in terms of pediatrics.
I think the question is
I just need,
about
sorry.
adults, isn't it? I think Marie wants to know whether it's changed for adults as for APLS. Is that right, Amir? Is that
Sorry, my
Yes.
question, sorry, was you mentioned in the previous presentation that rather than going straight on to cardiac compressions, you would want to secure airways. Is there such a thing in the pediatric population? Are we trying to secure airways and obviously take airway precautions before we do anything else first?
Yes. This is the national guideline which says that in order to reduce the aerosol generation minimization, you need to maintain the airway first by intubating the patient before jumping on to start the CPR. But as I said, that's in children, it's a very low incidence of having the COVID-19. So if the patient is not COVID-19 and we know that it's not COVID-19, then we can follow the usual steps of doing the CPR.
Okay, thank you.
Thank you, Mariam. Thanks a lot. And the next question is from Shakil. It says, presently, COVID-19 cases are declining in Pakistan. It is observed that in villages, the COVID cases are less, although they're not following the SOP. They're doing the routine activities as usual. Is there any resistance they develop? Panelists, please.
Not as far as I know. Obviously, there are studies still going on in terms of resistance, in terms of antibodies, and in terms of further testing. But as far as my understanding is, there's no studies that suggest whether there's any resistance against the COVID-19 virus in the human body.
Okay. Dr. Habib, Dr. Nabil, if you want to add up anything before I move to the next question, please.
No, I think I agree with Dr. Omar Khan, as such that we have no objective evidence that there is any resistance or not. But people are saying that they sometimes present with the delayed complications. So nobody can exactly get the exact answer, what are those complications are. But definitely they presented, because COVID illness has a different phases. So sometimes they have initial phase for 7 to 9 days. When people survive their episode, then they're out of immediate danger. But if they're going to be declined, they're going to decline in first 7 to 10 days. But I agree with my colleague, they're not as such a resistance evidence.
Thank you. And last question is that how often is the patient moved between the specialties? It's an interesting one, actually. After arriving in emergency department, does that risk increases to cross-infection?
I think from the emergency department point of view, obviously the main purpose of this specialty is to differentiate between patients, to identify them really early and really quick. Yes, there might be some loopholes. Yes, there might be some out of the net, but the whole idea is not to move them. And in the next case, I will explain to you a bit more about this move. But the idea is to have a destination for them right at the very beginning. Luckily, here in Queen's Medical Centre or Nottingham University Trust, we've had, right from the very beginning, we were able to establish fixed guidelines and rules and policies. And based on those, we were very easily at the doorstep able to decide which patient can go to which ward. In the initial stages, obviously, the symptoms were not very clear. So there were patients who slipped through the net who did not come with very common or known symptoms of COVID, and they were sent to wards which they were not supposed to, only because we did not have enough information around the world. But as information started coming out, as there was more research and information available, we were able to then send patients directly to the very appropriate wards that they were supposed to go to.
Thank you, Dr. Umar. I think these are the questions we've got so far. I'll keep on updating at the end. So I think we can move on to...
Sorry, can
Sorry,
you
Dr. Habib.
one thing to answer for the last question?
Yes, please. Yes, please. Dr. Habib, over
Yeah.
to you, please.
So, no, I agree that Umar explained very well. We also have in our hospital in Derby, like different divisions, red and green divisions. So we try our utmost best to stick them with the same specialty and also the same area. But in case if the need arises, the patient safety and the safety of others is the main priority for us. So we need to transfer them to the red area, to the other red area, but without minimizing the further risk. But it depends upon and varies from patient to patient.
Thank you, Dr. Habib. This ends up case number 2, and then I'll hand over the voting to Dr. Umar yet again for case number 3. Dr. Umar, when you are ready, happy for the third case to go on then. Thank you.
So third case and last case for today, very interesting, something that is very close to my heart, something that we in emergency medicine practice a lot, be it clinicians or nurses or the staff around in the department. We thought we'd bring this case forward, possibly a different concept than that being practiced in Pakistan, just to sort of give you an idea of slightly different way of working here in the UK. So this is a 70-year-old man who is from a nursing home, who's housebound, who doesn't go out of the nursing home. His background is hypertension, diabetes. He's high BMI as well, so he's on the obese side. He's been short of breath the past 2 days with cough and fever. He's been brought into the emergency department with slight tachycardia of 102, with a respiratory rate of 26, more than normal. Obviously his oxygen saturations are very low, which is 92% on 8 liters of oxygen, and his respiratory rate is high. Again, the usual investigations start from the doorstep. We've identified he's possibly COVID. We've identified that he needs to come into possibly resus because his oxygen requirement is going up. We've done a chest x-ray which shows consolidation. We've done bloods which eventually results have come back and show his white cells normal, but he's a bit lymphopenic, something that we see in COVID patients, and his CRP is raised as well. He's got kidney injury as well, so his kidney function has declined on a background of already low kidney function. In terms of management of this patient, as an emergency physician, part of our job is not just to manage the very sick, the very unwell patients in a very time-critical manner. Part of our job is to look at, if you remember, I said psychosocial aspect of the patient, and to manage the patient's relatives. Now, medical side of things, as you'd expect, we've investigated, we've established our diagnosis, we've started treatment, we've given him titrated oxygen, plus minus some fluids, antibiotics, urine output with a catheter. Obviously, the next step is to now decide, if you remember I said my thought process would start right from the beginning and thinking where this patient is going to go. Based on the history, this patient's 70 from a nursing home with housebound with absolutely low physiological reserves. This patient will not be a very good candidate for intensive care from his background that we've established, based on the history, based on the presentation that we have today, based on the chest x-ray and the blood findings. So for the next biggest step in our way of working, so me as an emergency physician will then at that stage decide, right, okay, so this patient will not go to intensive care because he will not do very well. And also he will probably be, if we went down that route, he will suffer more than to be treated in the right direction. In order to now, we've decided this treatment, but to pass that on to the patient and to the relative is the biggest challenge that we face on a daily basis. Not just because it's a very difficult communication, but also it's very time critical. So now I have to speak to the family over the phone and explain to them what the plan would be and how this patient's going to go. Something that we practice very commonly in the UK is do not resuscitate or respect forms, which ideally is discussed with the patient when they're well as to what their wishes would be if they became really unwell and their chances of improvement wasn't great or wasn't there at all, whether they would like not to be resuscitated, and then a DNAR form is put in place. If that's not done beforehand, then as a first clinician, as the emergency physician, my job is to decide whether that needs to be put in place to maintain that patient's dignity right at the doorstep, or whether there's an advance directive put in place by the patient or the family. So I've decided that this patient's ceiling of care is ward-based and not critical care. I have now, my job is to speak to the family over the phone who cannot come to the hospital. So that is a very emotional, very intense communication over the phone to explain to them what the benefits are and what the consequences will be if we decided to go the other way around. So that's what we do in the emergency department. We establish a ceiling of care for these kind of patients. We then discuss with the family and come up with an agreement or an expectation as to how far we're going to go, what we're going to do, what we are not going to do, and at what level this patient, or at what stage will we say that we've achieved the maximum intervention we could do in the hospital and we are going to now stop and go down the end of life route. So that's what we kind of touch base in the emergency department in a very time specific manner, just because of the flow of emergency department is very constant and very hard. Therefore, we've got to keep that in a time specific manner as well. So I would have that chat over the phone with the family, and then I will have a chat with my acute medical colleagues, and I will explain that we've decided that this patient should be for ward-based care only, should not be escalated to intensive care because the outcome is not achievable, or a good outcome is not, the prognosis is not very good in this patient. And then again, it's not just that one-off discussion with the family or the patient. It will happen at every step of that patient's journey. So after the emergency department has had that discussion and reiterated, our acute medical colleagues will then reiterate and have that discussion again, and then the ward will have that discussion on various steps of the journey to make sure that the family understand, the patient understands. So from management side of things, this patient's had what we could potentially give as a maximum. Now this patient's now being referred to acute medicine to carry on forward. So I'd let Dr. Habib tell you what happens next. You're on mute, Dr. Habib.
Thank you, Umar and Nabil, regarding the previous scenario. And thank you, Umar, for explaining very well about the initial presentation of this patient. As you guys know that my ED colleagues already decided this patient is probably not suitable for intensive care. So we're going to start in terms of criteria. It fulfilled the criteria for Pakistan point of view is a severe criteria, which means that it has feature of pneumonia, respiratory rate is very high, and his oxygen levels are very low. So in Pakistan setting, he should go to high dependency unit with negative pressure. As my colleague already explained about the different levels, and we have discussed before that this patient is probably not suitable in terms of his presentation. Previous. So we're going to start with history and examination in terms of acute medicine setting. This patient is very frail enough, is about 70 years old, and also had a multiple comorbidities. And also according to the risk factor profile, he has age, which is around 70 years, but he has a high BMI, which is one of the risk factors. Then he has a multiple comorbidities, including the kidney problem and hypertension, Plus, he's in long healthcare setting, what we call nursing home resident and housebound. So obviously, he's a candidate not suitable for intensive care as the ED team has discussed. But I'm going to tell you the scenario that when this patient comes to us, we need to have second discussion with them. Start with initially medical management plan in which we're going to compromises on symptom control and also giving him controlled oxygen and then monitor their fluid status. Because it's very important, because when we're going to give them fluids, we need to make sure they should be euvolemic rather than hypervolemic, which can increase the risk of hypoxia, decreased oxygen, which also contributing due to COVID-19. Secondly, we need to start them on dexamethasone, as we discussed before, because when the oxygen requirement is high, dexamethasone is now routinely used in UK to deal with COVID-19 patients. But when we're starting dexamethasone for patients who are very sick enough and in the about above 65 years of age, the risk of delirium, what we call psychosis, steroid-induced psychosis, plus minus other side effects like high blood glucose. So we need to monitor them closely. And then we can have a discussion with family. Again, it's very difficult task. You guys can imagine that we're dealing with COVID era. So everything need to discuss with on the phone to decide about this patient is very well, very unwell. And we need to decide about what we need to do in terms of in case if we deteriorate. So we have different care bundles in UK setting. First of all, we need to establish whether there is any advance directive, whether he has any previous wishes, that what we need to do in case of he can't able to make his decision. Then we need to involve sometime the people who have a power of attorney, like next of kin. But in UK, should be make sure that they have a power of attorney for health rather than only finance. Then we can discuss with them if the person cannot make a decision, what we call they did not make their own consent. And then we need to involve with our other colleagues to make sure to have a second opinion, which we can discuss subsequently with our ITU colleagues. But right now, we also need to establish in case if we deteriorate, then whether he need a candidate, what we call as an amber pathway or end of life pathway, in which we're going to give them symptom control and help them in terms of their management. These are the specific setting criteria in UK only. I'm not sure, it's very difficult in terms of Pakistan setting, so I don't want to talk anything about the Pakistan setting. I'm just concentrating on the UK basis. So obviously, I'm going to take a second opinion from my intensive care colleagues regarding his suitability, so we can actually emphasize and then also convince the family regarding our decision that is not suitable for ITU and only for ward-based care only and symptomatic management.
Okay. Thanks, Dr. Habib, for referring this patient and ask an opinion from the ITU. So I will just briefly discuss this case scenario which we have discussed, and what are the what is the gold standard for making a plan for these patients. So we have a gold standard framework for the patients whom we think that they're not really suitable for the ITU. Even if we give them any organ support, is not going to help their fate and not going to prolong their life. So I will just briefly discuss three case scenarios in which we think that these patients, their fate might not be affected if we can even admit them to the ITU or provide them any organ support. The first case scenario is a patient with who's having a cancer, and he's been having active cancer disease, and he has got we are not really sure that whether he has got metastasis as well. So these patients normally they go okay along the course of their illnesses, but once if they catch any infection or anything happen, and they've been admitted to the hospital, they had a rapid decline and they might not be able to recover from that illness. So these patients, which we think that even if they come to the ITU, we are not going to change their lifespan. So obviously these patients are not suitable for the ITU admission. The next patient which I would like to discuss is another old frail patient having multiple comorbidities and had quite a few admission to the hospital, and with every hospital admission they had a rapid dip in their health, but they recover. But obviously with every admission to the hospital their health is gradually progressively declining, and if they develop any illness or COVID-like symptoms or any any other illness, that will probably will end up their life, and they're not going to be benefited with the ITU admission. The third patient, obviously, it's a housebound patient. Normally, they live in a care home, and they are old, frail patients, and having dementia and other comorbidities as well. And they're not doing obviously really well. But they are obviously on their lifespan. They are already on a decline side, and if they catch any infection or anything, and they're not going to survive from that, and we would not be benefited from any organ support. So these are the three clinical scenarios which I've just discussed, and they're based on this gold standard framework. We think that these patients are not really suitable, and the ITU organ support is not going to help them in any way. So these are not basically the candidate for the ITU. Next.
Thank you, Dr. Nabil. Does that end up the case 3 from your side? Dr. Nabil, can you kindly unmute, please? Yes, thank you. So that ends up case 3. Thank you so much for this wonderful session. I'm sure all of the attendees would have enjoyed. Sorry. Yeah. So I've got a couple of questions. The first is from Katerina. It says, did you recruit the 2 patients admitted to hospital to the recovery trial? Can you elaborate on that? Which 2 patients you're talking about? Case 1 and case 2, Katerina, or case 2 and case 3, if you're still there?
Hey, so it's about the case 2 and case 3. They were admitted. The first one went home.
Okay. Panelists, please.
Okay, so I was involved in terms of recovery trial as a part of acute medics, because these patients came to the emergency department and transferred to us, and then we have a good research team who gave us this explanation. So the answer to this question, we have done random selection of patients regardless of age, sex, or comorbidities. So yes, these patients definitely the part of the recovery trial.
That's fine. Thank you. And next, thank you so much, Katerina. The next question is from Mr. Kashif Chauhan, and that is, what kind of fluid do you recommend to give, which is appropriate in these conditions with patients who are overloaded on dexamethasone and high blood pressure with COVID-19?
So again, it's a quite difficult scenario and very important question, because we need to establish at that time whether patient is suitable for the ward setting or fulfill the criteria that whether we need to escalate the care. Because we're not dealing only with hydration status, we're dealing with probably complication to it. The person who's already had a heart failure and superimposed fluid overload, then definitely they're not a good candidate to give them fluids despite of septic or septic shock. So we need to establish with the help of ITU colleagues whether they are candidate for intensive care or level 2 care, which include inotropes. And then in terms of dexamethasone, we need to think about it, whether this could be a synergistic effect in regarding the fluid overload, which is could be combination of heart failure plus minus side effects or a complication of dexamethasone, whether we need to decrease the dose, which means we need to have a team decision to decide whether we're going to escalate the care or patient is getting deteriorate, and we may need to consider a palliative care with the help of family and involve the palliative team.
Dr. Habib, I can't hear you. If you just...
You can hear me now?
Yes, yes, please.
Did you hear my answer?
Yes, yeah, I heard just the last sentence. I think you're trying to wrap it up. What is the last sentence you just mentioned? Sorry.
I'm just saying the last sentence was that regarding the escalations. In case if the patient is getting deteriorate and is already been established for ward-based care, then we're going to have final decision with the family to make sure whether we're going to make them comfortable and involve the palliative team and take it from there.
Fine. Thank you, Dr. Habib. Next question is from Wahid. It says, is there any role of nebulizers in patients on high oxygen requirements and the role of antivirals like Tamiflu in such patients?
So as far as I gather, in our hospital, there are no such rule of antiviral but nebulizer, as my colleague already explained in the beginning, the ED physician, Umar Khan, that they can use nebulizer for symptomatic control, like for wheezing. And overall, nebulizer is going to help, like in terms of bronchodilator effect, to help the oxygenation delivery, and eventually going to improve the hypoxia.
I guess from an emergency medicine point of view, the only thing I would say in terms of nebulizer is because we don't have, when the patient comes to us initially, we do not have a diagnosis. So they're all suspected COVIDs. Even if there's chest signs or chest infections visible on chest x-ray, the treatment would be more symptomatic as opposed to more COVID directed. So if the patient's wheezy, if you suspect bronchospasms, then we do start nebulizers. In some patients we see symptoms, in others, so it's just a patient by patient care. But from the starting point of view, from the emergency medicine point of view, if we suspect bronchospasm or bronchoconstriction, we do give nebulizers.
It's fine. Thank you so much. Any other questions? Anyone wants to put up a verbal question or any question in the forum? Please feel free to do it now before we try to close the session. Any additions from anyone who's still on the forum? Just one request. I'm not sure Dr. Bashir Somro, is he still there? He's one of the professors of neurology at Ziad University, Karachi, and faculty and secretary of neurology at CPSP Pakistan, sir. Would you want to add up, if you're still there, if you want to add up anything, sir, in this session and your experience or things going on at your end, are there any different, briefly, if you can, if Dr. Bashir Samar is still there and he can hear me.
Thank you so much for taking me on the forum. We had in 4 months of COVID era, we see a lot of patients who have neurological complications, and they do directly come either to the emergency medicine or they do visit our visit. But it is very difficult to handle them because we do not know, because testing capacity is very low here. Or so we in neurology, we saw patients and who have lot of neurology complications like stroke, posterior circulation stroke, and cortical venous sinus thrombosis. And recently I saw a patient, she has a paralysis and she has a GBS, and she become weak after the interval of 3 weeks of COVID. She had a COVID, and after 3 weeks of COVID, she had a paralysis and she is unable to walk. And so we conducted a test and she's being managed. But here we saw a lot of pulmonary cases rather than neurological cases. So my intensive care unit colleagues, they are managing very well, but mortality is very high, you see, because the non-availability of medicines. Initially, the people were trying hydroxychloroquine and few other medications. And so this is all about this thing. Still, we are seeing COVID patients, and this is sporadic. Maybe it go on. How much one will never know how much it goes on. But there are cases of COVID who had neurological complications. Thank you.
Thank you so much, Dr. Bashir. So that was really a good addition from Pakistan. So if the panelists are happy and so are the attendees, I would really be thankful again for all of them to put up this brilliant session, a very informative session. Dr. Habib, Dr. Nabil, Dr. Omar, what do you want to add up anything from your side before I try to close up the session, please?
I just need to say once again, thank you to my co-panelists and NODFA, Nottingham Doctors Family Association, and a special thanks to Yaran Watan. Those gave us this opportunity to increase the awareness of COVID-19. And as a lead of medical wings of NODFA, I think it's a really good opportunity for all of us to share our thought process and increase the awareness in the public, and also using the Yaran Watan platform to increase our experiences and provide our services to Pakistan people. And it was a privilege that Dr. Bashir Somro joined us from Pakistan. He's a well-known figure, and he already in that way and invited us to do some of the services there. So we are more than happy with our team. And again, I'm thank you to Nabil, who joined us at 11th hour, despite of absence of Mohsin Zaman, who unfortunately didn't make up today. So I think it's a great team efforts, guys, and we will carry on and keep it up. Well done, team.
Thank you
I
very
would
much.
like I would like to just
Dr.
say
Nabil.
some remarks. I would like to thank again NODFA and Dr. Habib just to give me the opportunity to share this experience. It's really a good experience, and I hope everybody enjoyed here the experience which we shared. And I really want to thank especially Dr. Habib as well, who just keep motivating me to do this session. Thank you.
Dr. Omar, please.
Again, thank you very much to NODFA and to Yaran Watan for giving us this opportunity to come along and share our experiences. I hope we've served some purpose, and I hope the information was good enough for people around in Pakistan and in the UK. If there's any more questions at any stage, please feel free to ask, and we'll be happy to answer.
No, that's as well said, Dr. Omar, Dr. Habib, and Dr. Nabil. Definitely, well, being personally a surgeon, you've turned Latin a little bit more into Urdu after all this session. So I've learned a lot about medicine, ITU, but obviously I can never be to that point at all. So again, as a personal thank you to all of the three panelists. Dr. Mohsen, I hope you're fine, and sorry you're going to be able to attend. Thanks a lot to Yaran Watan, and we will be offering our services, Nottingham Doctors Family Association, headed by Dr. Kashif Chauhan, and the teaching wing for any support. As I said earlier, thank you so much for the attendees to give your Sunday morning to this informative session. The reason of doing this Sunday morning was basically we wanted our colleagues and doctors back in Pakistan to come at a very good time at 3-4 o'clock rather than starting this session at 6 or 7 o'clock. What we plan to do at NODFA, I said it before, I'm saying it again just for the reason, it's your forum. You please come forward. Our email is nodfateaching, NODFA TEACHING @gmail.com. If you've got any session you want to put up with the help of your co-speakers, or if you've got any session you want us to organize, please feel free to contact, and we will definitely try to do that. We're going to run up a few more sessions in this month. I will put up the schedule hopefully in the next 2 to 3 days. We will be trying to touch base every sort of system. As I said earlier, we try to do sessions, knowledge-based clinical experiences. Special thanks to Dr. Omar. After being on nights, I'm still not feeling sleepy at all. Dr. Nabil, thanks for being with us the very last minute. And Dr. Habib, thank you for leading as a medical wing of the teaching. And I think with this, thank you so much. And obviously, thank you all of my team. And obviously, how can you forget Dr. Kashif Chauhan, the president of NODFA Doctor Family Association. So I would like to say thank you to everyone for attending. I think we'll call it a day. Any suggestions, you can always email us.
I'll tell you,
Dr. Kashif, please.
Before you call it a day, I really like to thank the panel. My special thanks to Dr. Habib Haider, who has very kindly come on board on NODFA as a lead of medical wing. So Dr. Habib Haider, thank you very much for that and for your services. I also like to thank Dr. Nabil and Dr. Umar for an excellent session. Despite of the fact that I'm a pediatric surgeon, I understood that what you were talking about, which is very difficult for a surgeon to understand what the medics are talking about, but that was an excellent session. Lastly, but the most important, I like to special thank Dr. Bashir Somru for joining us. NODFA is privileged for you to be on board, and we will look forward for your advices, for your support, for your sessions in future also. So on the behalf of NODFA, thank you very much. Obviously, I like to thanks Yaran Watan also for giving NODFA the opportunity to spread the education and teaching to our country, which I owe, or which all of us, owes a lot. But nothing was possible without the participants. So a special thanks from the president of NODFA, Dr. Kashif Chauhan, to all the participants who came over here. So back to you, Amir.
Yes, sorry. So just on the thing, Dr. Habib has also added up his email address. So any suggestions from the medical wing regarding the courses, sessions you need, we know that, most of the, not only for the local graduates, for international medical graduates, most of them touch-based medicine and accident emergencies. So if you've got any suggestions for the seminars or topics you need, you can also email Dr. Habib Haider or NODFA Teaching. Last but not the least, a couple of things. This session has been run for around 1 hour and 40 minutes. So then technically we can be getting, I think, 1 to 1.5 CBD points. This has been asked to me a couple of times in the last couple of days. So yes, you can get 1 CBD point for sure, attending for 1 hour, probably to be 1.5 to depending, because it's normally 1 hour for one session. You can show the poster, you can get back to the, Yaran on the website to get the timing as an evidence. However, if anyone of you, because I know in the audience, there are people ranging from who are still not given PLAB, and thanks for them to joining, up to the consultants. If you want any sort of evidence or thing, you can always contact nodfateaching@gmail.com, and we can provide you with it's going to be a certificate, but you're going to put up your own CBD points for that purpose. So I think that is it from our side. I will probably, with the help with the support of anyone else, try to end the session then. Thank you everyone again. Take care. Have a very good afternoon.
Thank you.
Bye-bye.
Thank you.
Thank you.